Hello, everyone. Dr. King back again, and I'm here to talk to you a little bit today about neurocognitive disorders. And these disorders occur a little bit later in life. So let's get started, for the most part, later in life. Okay. So neurocognitive disorders affect learning, memory, and consciousness. Most develop later in life, and the types of neurocognitive disorders you may see are delirium, temporary confusion and disorientation, major or mild neurocognitive disorder, which is broad cognitive deterioration affecting multiple domains, and amnesic, so refers to problems with memory that may occur in neurocognitive disorders. It can cause profound changes in behavior and personality. And while these are considered to be general medical conditions, sometimes it can be best treated by mental health professionals because you may be helping the family member and the person manage some of the changes or deteriorations that are occurring. So delirium, what is delirium? The nature of delirium includes impaired consciousness and cognition, develops rapidly over several hours or days. So that it's a really fast onset. And people appear confused, disoriented, or inattentive. And it's marked memory and language deficits. So people have a lot of trouble remembering what's going on, and their language may also be impaired. So this can affect up to 20% of adults in acute care facilities. It's more prevalent in certain populations, including older adults, those undergoing medical procedures, AIDS patients and cancer patients, and full recovery often occurs within several weeks. So delirium is typically temporary. So you're going to look for, this is the criteria for delirium, a disturbance in attention, reduced ability to direct focus, sustain, and shift attention, and awareness, reduced orientation to environment. The disturbance develops over a short period of time, usually a few hours to a few days, represents a change from baseline attention and awareness, and tends to fluctuate in severity during the course of the day. An additional disturbance in cognition, memory deficit, disorientation, language, visuospatial ability, or perception. And the disturbances in A and C are not better explained by another pre-existing established or evolving neurocognitive disorder and do not occur in the context of a severely reduced level of arousal, such as coma. And there's evidence from the history, physical examination, or lab findings that the disturbance is a direct physiological consequence of another medical condition, substance intoxication or withdrawal, due to drug abuse or to a medication or exposure to a toxin, or is due to multiple etiologies. So again, this is temporary, it should pass. Medical conditions related to delirium. So 50% of dementia cases involve temporary delirium. Drug intoxication, poisons, and withdrawal from drugs. So if you're working in a drug inpatient facility, you may see some of this in the detox unit. Infections and head injury and several forms of brain trauma can cause this, and sleep deprivation, immobility, and excessive stress can cause it. Treatment involves attention to precipitating medical problems, so making sure that anything that could be causing it is taken care of. You want to reassure the person, provide comfort, help them with coping strategies, and include the patient in treatment decisions. So a common form of mistreatment of individuals who are struggling with neurocognitive disorders is that other people decide that they should make all the decisions for them. And while you may need to help them and assist them and make some decisions for them, you want to give them as much autonomy as possible over their treatment options and help them make decisions. And prevention. So we want to address medical care for illnesses, proper use and adherence to therapeutic drugs to try to prevent this if possible. Now we're moving on to major and mild neurocognitive disorders. Nature of dementia. So gradual deterioration of brain functioning, deterioration in judgment and memory, deterioration in language, advanced cognitive processes, has many causes and may be irreversible. So while the dementia could be reversible and it's kind of connected to maybe something someone's going through, medical treatment or a medical issue, this is, we're moving into more permanent neurocognitive disorders. So a major neurocognitive disorder is the new DSM-5 term for dementia that's long-lasting. Mild neurocognitive disorder is the new DSM-5 classification for early stages of cognitive decline. So early stages of cognitive decline would be in the mild category. More advanced, more permanent would be major. So in mild neurocognitive disorder, the individual is able to function independently with some accommodations. So as a mental health counselor, you would probably be helping them manage their life in a different way, maybe help them organize themselves in ways that could help them stay on track, or help family members structure their lives in a way that will help them stay on track. Major cognitive disorder. So that includes one or more cognitive deficits that represent a decrease from previous functioning. It's substantiated by clinical assessment and interferes with daily independent activities. So the person with major neurocognitive disorder may struggle a little more to function in daily life. The criteria summary for major neurocognitive disorder includes evidence of significant cognitive decline from a previous level of performance in one or more cognitive domains: complex attention, executive function, learning and memory, language, perceptual, motor, or social cognition, based on concern of the individual, a knowledgeable informant, or the clinician that there has been a significant decline in cognitive function. And 2, a substantial impairment in cognitive performance, preferably documented by standardized neurological testing, or in its absence, another quantified clinical assessment. So here's where you would want to do a mental status exam. And B, the cognitive deficits interfere with independence in everyday activities. The cognitive deficits do not occur exclusively in the context of a delirium. And the cognitive deficits are not better explained by another mental disorder. And we're going to specify whether it's due to Alzheimer's disease, frontotemporal, lobar degeneration, Lewy Body disease, vascular disease, traumatic brain injury, substance or medication use, HIV, Prion disease, Parkinson's disease, Huntingtons disease, another medical condition, multiple etiologies, or unspecified. Mild neurocognitive disorder is evidence of modest cognitive decline from a previous level of performance in one or more cognitive domains: complex attention, executive function, learning and memory, language, perceptual, motor, or social cognition. Based on concern of the individual, a knowledgeable informant, or the clinician, there's been a mild decline in cognitive function and a modest impairment in cognitive performance, preferably documented by standardized neuropsychological testing, or in its absence, another quantified clinical assessment. So the cognitive deficits do not interfere with capacity for independence in everyday activities. The cognitive deficits do not occur exclusively in the context of delirium. And the cognitive deficits are not better explained by another mental disorder. So this is very similar to major neurocognitive disorder. It's just mild, and the person can engage in daily activities. And you want to specify whether it's due to previously mentioned other diseases from the last slide. Major neurocognitive disorder. A new case is identified every 7 seconds. There's a 5% prevalence in adults 65 and over, 20% prevalence in adults 85 and over. There's a prevalence of mild neurocognitive disorder is greater. 10% of adults 70 and greater have a mild neurocognitive disorder. The initial stages include memory and visuospatial skills impairments. So, losing the memory, maybe having trouble getting around, maybe struggling to drive. Facial agnosia, an inability to recognize familiar faces. And other symptoms include delusions, apathy, depression, agitation, or aggression. Later stages include the cognitive function continues to deteriorate, and total support is needed to carry out day-to-day activities, and increased risk for early death due to inactivity and onset of other illnesses. Okay, so types of major and mild neurocognitive disorders. So you just want to specify if these neurocognitive disorders are onset due to Alzheimer's disease, frontotemporal, vascular, with Lewy bodies, due to traumatic brain injury, substance or medication induced, due to HIV infection, due to Prion disease, due to Parkinson's disease, due to Huntington's, or another medical condition due to multiple etiologies, or unspecified. Neurocognitive disorder due to Alzheimer's disease accounts for nearly half of neurocognitive disorders. So that's why it's, pointed out so prominently in the DSM. The clinical features include typical development, gradually and steadily, memory, orientation, judgment, and reasoning deficits. Additional symptoms may include agitation, confusion, combativeness, depression, or anxiety. So that might be a good assessment. You're always going to want to assess for mood of the person who may be struggling with some of these cognitive deficits, because it's likely that they're struggling with depression and anxiety as well. So in order to, the diagnostic criteria for major or mild neurocognitive disorder due to Alzheimer's includes the criteria being met for major or mild neurocognitive disorder, insidious onset and gradual progression of impairment in one or more cognitive domains, or more major neurocognitive disorder, 2 domains must be impaired. The criteria are met for probable or possible Alzheimer's disease. And I'm not going to read out the whole Alzheimer's disease criteria, but take a look at that. And then for mild neurocognitive disorder, there's a decline in memory and learning, progressive, gradual, and no evidence of mixed etiology. So since we're not medical doctors, you're gonna have to depend on those medical doctors to give a diagnosis of Alzheimer's. It's a little outside of our wheelhouse, so just be aware of that. Okay, so characteristics of neurocognitive disorders. So this, what we really want to know is that neurocognitive disorders affect language, they affect memory, they affect visuospatial skills, mood, motor speed, and coordination. And so just be aware of that and take a look at this. Okay, so the statistics related to neurocognitive disorder due to Alzheimer's. So there's a nature and progression of the disease. There's a Nun study conducted, and that included an analysis of Nun's journal writing over many years to show the patterns of deterioration, and early and later stages slow, and during middle stages rapid. Post-diagnosis survival is 8 years. Onset is in the 60s or 70s. Early onset can occur in the 40s or 50s, and 50% of cases of neurocognitive disorder result from Alzheimer's disease. About 5 million Americans and several million worldwide suffer from neurocognitive disorder due to Alzheimer's. It's more common in less educated individuals. More educated individuals decline more rapidly after onset, which suggests that education simply provides a buffer period of better initial coping. It's slightly more common in women, possibly because women lose estrogen as they age, and estrogen may be protective. The extent of deficits. So there's a range of cognitive deficits: aphasia, which is difficulty with language; apraxia, which is impaired motor functioning; agnosia, failure to recognize objects; and difficulties with planning, organizing, sequencing, and abstracting information. And there's a negative impact on social and occupational functioning. So these are some questions you might ask someone to try to get a feel for the level of decline. So you would say, what is the year, season, day, date, month? Ask the patient where we are. Name 3 objects using 1 second to say each. Then ask the patient all three after you've said them. Give 1 point for each correct answer, then repeat them until the patient learns all three. So this is kind of an example of a test that you would give for neurocognitive disorder due to Alzheimer's, but you could probably give this for all of these neurocognitive disorders, counting backward from 100. Have a patient name 3 objects learned previously. So that's recall and memory. And then have the client name certain objects like a pencil and a watch. Have someone repeat a line. Have them complete simple commands. So this is a mental status exam that you would want to give. Also, you would want to get trained in this and work with this population specifically to start doing this. I wouldn't recommend it if you're just working with older adults in private practice or outpatient somewhere. Here's a picture of a brain afflicted with Alzheimer's disease, which is on the left, and a normal brain on the right. So you can see that there's significant tissue deterioration in comparison with the normal right brain, which causes all of these deficits and issues with functioning. Let's talk about vascular neurocognitive disorder. And this is caused by blockage or damage to blood vessels, and it's the second leading cause of neurocognitive disorder after Alzheimer's. The onset is often sudden, so this can occur due to a stroke. Patterns of impairment are variable, and most require formal care in later stages. So some of the features include cognitive disturbances that are identical to dementia, obvious neurological signs of brain tissue damage, and the prevalence is 1.5% in people 70 to 75, and 15% for people over 80, and it's slightly higher risk for men. So I'm going to skip over this. It's very similar to a lot of the others. Frontotemporal neurocognitive disorder broadly refers to damage to the frontal or temporal regions of the brain affecting personality, language, and behavior. 2 types of impairment would be decline in appropriate behavior and decline in language. So the frontotemporal lobes, the frontal lobe of the brain affects your personality, your language, and your behavior. So these are the first things to go. Maybe an issue of a brain disease, anything that affects the brain can affect the personality. So that's something to be aware of. Neurocognitive disorder due to Pick's disease. So this is a rare neurological condition that accounts for 5% of all dementia diagnoses. It produces a cortical dementia like Alzheimer's. It occurs relatively early in life, around the 40s or 50s. And little is known about what causes this disease. There's also neurocognitive disorder due to traumatic brain injury. Accidents are the leading cause, and symptoms can last for a week after head injury, including problems with executive function, learning, and memory. Memory loss is the most common. This is found in athletes who experience repeated blows to the head, and I'm sure you've heard a lot of the research that's come out about how this also impacts mood and possible suicidal ideation in these athletes. So you can take a look at the criteria there. So basically this is the same. They meet the criteria for major or mild neurocognitive disorder, but there has been evidence of brain injury. And neurocognitive disorder due to Lewy body disease. So Lewy bodies are microscopic protein deposits that damage the brain over time. And the symptoms onset gradually, and they include impaired attention and alertness, visual hallucinations, and motor impairment. And of course, the criteria has to be met for major or mild neurocognitive disorder. It has an insidious onset and gradual progression, and they have to meet the criteria for having the Lewy bodies. Neurocognitive disorder due to Parkinson's disease. So Parkinson's is a degenerative brain disorder, and it does dopamine pathway damage. 1 out of 1,000 people are affected worldwide. So, it's uncommon, but definitely happens. Chief difficulty includes motor problems, tremors, posture, walking, speech. Not all with Parkinson's disease will develop the dementia, and 75% survive 10 plus years after diagnosis. So you can take a look at that. Neurocognitive disorder due to HIV infection. So HIV can cause neurological impairments and dementia in some individuals. That's characterized by cognitive slowness, impaired attention, and forgetfulness, apathy and social withdrawal, and typically occurs late in the later stages of the disease, and now occurs in less than 10% of individuals because HIV is being treated so well nowadays, which is, of course, great news. Okay, so you can take a look at this criteria as well. And neurocognitive disorder due to Huntington's disease. So Huntington's disease is a genetic autosomal dominant disorder. It's caused by a gene on chromosome 4. It manifests involuntarily, initially as involuntary limb movements, usually later in life, and somewhere between 20 to 80% display the neurocognitive disorder. So it's a little more common with Huntington's disease than Parkinson's. Dementia follows a subcortical pattern. And you can take a look at that. And neurocognitive disorder due to Prion disease. I'm not even sure if I'm saying that right. I've never heard of Prion disease until, digging into the DSM. So again, this is something you would want to depend on a doctor to help with your diagnosis because you're not going to know how to diagnose prion disease. So disorder of proteins in the brain that reproduce and cause damage. There's no known treatment and it's always fatal. And it can only be acquired through cannibalism or accidental transmission, contaminated blood transfusion. It affects 1 out of 1 million persons and it's linked to mad cow disease. So that is probably why I have not heard of this, because it is very rare and it's linked to cannibalism, which is definitely a socially unacceptable practice here in the United States. Okay, substance, medication-induced neurocognitive disorder. You may see this a little more frequently, like I mentioned before, in those detox centers. And this can result from prolonged drug use, especially in combination with poor diet. You may see this in alcoholics. So alcohol can cause this. It's called wet brain syndrome, particularly those who are neglecting their health in other ways. You can see it in sedative, hypnotic, anxiolytic, or inhalant drugs. The brain damage may be permanent. Often it's reversible once the person gets well and off the drugs, but not always. Symptoms can be similar to Alzheimer's. And deficits can include memory impairment, aphasia, apraxia, agnosia, and disturbed affective functioning. So how do we treat these neurocognitive disorders? Well, very few primary treatments exist. Most treatments attempt to slow progression of deterioration, but they can't really stop it. So really the idea is to help families manage it, help people manage it, help manage expectations, come up with plans to keep everyone safe, and process feelings, because there are declines in the individual, and if they're aware of it, then they might have some feelings about it, but there's also feelings in the family when this comes up and someone loses their loved one to a neurocognitive disease. So future directions include glial cell-derived neurotrophic factor stem cells, which may slow deterioration, and some drugs target cognitive deficits. So cholinesterase inhibitors, Aricept, Exelon, and Rimonel, and long-term effects are not well demonstrated. Exploratory treatments include ginkgo biloba. Drugs to treat associated symptoms include SSRIs for depression and anxiety and antipsychotics for agitation. All are only modestly effective for short periods of time. And they are currently testing vaccines on genetically altered mice to try to fix some of this stuff. And what can we do as mental health providers? We can enhance the lives of patients and their families. We can teach compensatory skills to manage the declines. You can use memory enhancement devices if needed. So example, having memory wallets containing statements about one's life, or even like safety medical bracelets and things to help the person, if they get lost or something, know where to go. Cognitive stimulation can delay onset, so caregivers get instructions on how to handle problematic behavior, including wandering, socially inappropriate behavior, or aggressive or rebellious behavior. And as I mentioned earlier, caregivers may also need mental health treatment or someone to talk to because they're under a lot of stress. So these are some sample assertive responses. So this is to help with the caregivers. So teach the caregivers how to manage the behavior of someone who's suffering from a neurocognitive deficit. And take a look at those. Such as, I know some of you miss some of the places we used to be. This is our home now, and together we're safe and happy here. I like to be treated just as fairly, just as you do. Let's discuss what's bothering you so we can go back to our usual good relationship. So just different things that you can say. And prevention of neurocognitive disorders includes reducing risk in older adults. So use of anti-inflammatory medication, controlling blood pressure, not smoking, leading an active social life. So general health, taking care of self, having good relationships. So as mental health providers, we can definitely help with the prevention aspect of helping older adults stay connected to their community. And other targets of prevention efforts include increasing safety behaviors to reduce head trauma and reducing exposure to neurotoxins and use of drugs. So, when we're working with our younger adults about their drug use, we can let them know that this is a prevention strategy for the neurocognitive decline that could come later if they don't get off the drugs now. So cognitive disorders span a range of deficits. They can affect attention, memory, language, and motor behavior. And causes include aging, medical conditions, abnormal brain structures, drug use, and environmental factors. Most result in progressive deterioration of functioning, and few treatments exist to reverse damage and deficits, but progression may be slowed. And that's all I have for you today. I hope you learned something about neurocognitive disorders. As mentioned, you may see this in hospital settings, or if you're working in hospice, or maybe like a care facility for older adults, then you may see these diagnoses frequently. All right, thank you so much and have a great day.